all the orthopedics and allied specialty branch fellows for the second episode of this orthobiologics with the idea of uniting the diversity of orthobiologics so that we can create a evidence-based literature in this upcoming branch of orthopedics. The idea of having this session or this series to educate all of us, because education is mutual and ever going, it's a continued medical education, so that we can get aware that new things are coming in orthopedics, just like today's session. And for today, we have a very interesting topic, the role of shockwave therapies in orthopedics. And we have the masters of this therapy. One is Dr. Daniel Moya, who is from Argentina. And Dr. Daniel is actually medical doctor graduate from Argentina itself. And now he is a past chairman of Secot Shoulders and Elbow Committee and is a past president of International Shockwave Societies and is a staff orthopedics department of Burns Aarons British Hospital. So I welcome Dr. Daniel. Second, we have Dr. Ram Chidambaram. Dr. Ram is again a very renowned orthopedic surgeon from Chennai. Dr. Ram is a Chennai upper limb unit head director and he was our president for Shoulder and Elbow Society of India from 2017-2021. And Dr. Ram is again conducting lot of educational program about this shockwave therapies of orthopedics in India. So I welcome both of our speakers, Dr. Daniel from Argentina and Dr. Ram Chidambaram from Chennai. Second, we have our educated moderators. Dr. Bishnu Patra Sahu is there. He is the head of the department at All India Institute of Medical Science, Bhubaneswar. Welcome, Dr. Bishnu. And Dr. Jujhar, who will join soon. He is a consultant at BSA Medical College. I have my colleague, Dr. Dharshan from Pune. So without wasting anybody's time, I would request Dr. Daniel to please start his presentation. And Dr. Bishnu, please welcome note from your side as a moderator.
Yeah. Hi, welcome all. This is a very interesting topic in the field of biologics, where you are not using biologics but using some shockwave therapy for regeneration. So it's also, you can say, it's a part of some section of biologics. So we have a great speakers today. We have Dr. Daniel and Dr. Ram Chidambaram, who are well-known figures in this particular field. And to start with, I request Dr. Daniel Moya to share his screen and start his presentation. Over to you, Dr. Daniel.
Thank you very much. Well, to begin, let me tell you that it is really moving to have the chance to share the experience, considering that so far there is not a lot of information in India about this. Many years ago, I had the chance to operate a patient in Costa Rica and was the first shoulder prosthesis in that country. And I have the similar feeling. In fact, was the world of shoulder surgery that took me in 1996, many years ago, to Germany, to the University Hospital of Munich, where I met Dr. Markus Meyer, who was beginning with his experience on the use of shock waves in musculoskeletal pathology. In fact, it was not a coincidence that in that same hospital, lithotripsy was developed, created and developed. So I began a long road. I have been using this procedure for the last 24 years. Of course, it is just one more tool that could be very useful for specific situations. Of course, it has also failures. So the matter is to analyze the advantages and the situations in which will not work. I will give you today an overview about the method. We will need to give some information about physics, but just a short information about that. And I expect that in the future, we will have the opportunity in different webinars to analyze specifically each pathology in which we have a lot of information. So to begin, we all know that there are two different types of waves. We can classify them in electromagnetic and mechanical waves. Today, we are discussing a mechanical wave. And shock waves, focused shock waves, are in the area of ultrasound. They are beyond audible sound. We have different types of ultrasound waves that are used in medicine for diagnosis and even for treatment. In this case, it's a very specific way, as the meter is in Paris, and we know that there is a definition of a meter, and we all appeal to that when we are speaking. We try to speak the same language. This is the real and specific definition of what is a focused shock wave. It is a very interesting phenomenon in which we have a high amplitude pressure peak, a short growth time of this peak, and this peak lasts for a short term, and it is followed by a rapid drop in pressure and by a negative wave. So this is what is real, and it is very well defined, a shock wave. Perhaps for us, talking about this makes difficult to realize the characteristic of these waves, but I will mention several times Dr. Achim Loske from Mexico. He is a doctor in physics that has been researching on shock waves for many years at University of Querétaro, and he gives us a very interesting example to make us know how different, how special is this wave. The time it takes to rise the shock waves and the rise time of the focus shock waves is 1,000. The bullet going through the pen takes 1,000 times longer than the rise of the shock waves. So we can imagine how fast is this wave, this focus wave. How can we generate this wave? Well, there are classically three types of devices: electrohydraulic devices that were the first ones that have been described, electromagnetic devices in the center, and piezoelectric devices. Today we have some variables. For instance, we have one crystal piezoelectric device, multiple crystals, but for you to know, the way we can generate it, shock waves are through these three basic options. I have worked with all of these type of devices. And on the other hand, we have what we call the radial pressure waves that unfortunately in the literature, not of course in all the papers, and in some fields in the clinical practice, they are named radial shock waves, but in fact they are not shock waves. Mostly these waves are generated by a pneumatic device, and this is the shape of radial pressure waves. As you see, they're completely different to focused shock waves. So something we must really make clear is that unfortunately, in the field of shock waves, we have two technologies. And I say unfortunately not because radial pressure waves are bad. I use them as well, but there is a lot of misunderstanding about both techniques. We have focused shock waves that are the real shock waves, and we have radial pressure waves. And we will see some differences between them. Here you can see both waves in the same diagram. And as you see, there is a big difference. Focused shock waves have a peak pressure that is 100 times higher than radial pressure waves, and radial pulse has a duration of, it lasts 1,000 times longer. So that picture of the bullet going through the pen, applies to focus shock waves, not to radial pressure waves. And as you can imagine, the effect of these waves in our bodies is completely different. Focus shock waves have a secondary focus. There is a primary focus in the device and a secondary focus in our tissues. And they go average deep 6 centimeters from the skin. Instead, radial pressure waves have most of the energy that is concentrated in the area of application, and they go some millimeters, some say 2 centimeters, up to 2 centimeters, according to the type of device, deeper from the skin. So the way these devices inject the pressure wave in patients is completely different. So when you consider the energy from the applicator with radial pressure wave, they drop sharply as you are getting far from the applicator, completely different to focus shock waves. And again, Dr. Achim Loske said that in fact would be dangerous if radial waves were focused, because we are delivering a large amount of, we would be delivering a large amount of energy over a big area, and that could harm the patient. And that fortunately does not happen. I have the privilege of being the co-author of this paper. If everyone is interested on it, I can send it to you, that we wrote with Dr. Loske, trying to make clear the nomenclature. Because if we do not speak the same language, it is difficult to share our information, to treat in a good way our patients, and to have conclusions about the results of different procedures. The interaction between pressure and life comes from the beginning, because the protocells began to develop in the oceans that were the primitive oceans, once there was a clear and adequate condition of temperature and pressure. So pressure is related to life from the beginning. And of course, pressure has a lot of influence in our lives. And we as orthopedic surgeons know how mechanics have influence in our bodies, especially in our bones. The first to begin using focused shock waves as a therapeutic procedure were urologists, as I told you, in the university hospital in Munich. But they were seeking just to destroy a stone in the kidney. They were just thinking about the mechanical effect of shock waves. And that worked. And that was a revolution. But were the urologists the ones who began to realize that there was not just a mechanical effect? Because they saw, when they were making the follow-up of the stones after shockwave application, that in the area where the shock waves were traveling to the kidney, there were some changes. And they, for instance, realized that in the iliac crest, there was bone formation. So they realized that something was going on, that there was a reaction, a response from the body. And these first papers were written by urologists. They checked the reaction of fractures that were produced in rats. One leg was treated with shockwaves, the other leg was the control leg, And they realized that those treated with shock waves had a faster and bigger development of callus than the other leg. The same happened with injuries that they perform in the skin of rats, and they realized that the healing of those injuries was faster and better when shock waves were applied. With time, some authors like Dr. Mikhailov in Bulgaria in 1986 and Dr. Damen in Germany in 1992 began to use shock waves for specific musculoskeletal pathologies. In the case of Mikhailov, who was an urologist working with Dr. Bakhanov, that was an orthopedic surgeon, they began to apply shock waves on non-unions with very good results. And Dr. Damen began to use it in calcifications of the rotator cuff. At the beginning, both authors were just thinking that they were producing mechanical effect, just that. Dr. Mikhailov told me, I had the chance to talk to him, that he was trying to refracture the bone, but now we know that that is not the mechanism. And Dr. Damen also thought that as was possible to destroy a kidney stone, it would be possible to destroy the calcification in the rotator cuff. But we know today that that is not the mechanism of action. They just trigger a biologic response. And again, Dr. Marcus Meyer, that I met back in 1996, he published in the 2000s this paper where he performed biopsies after applying shock waves to bone, and he realized that there was an increased activity of osteocytes and osteoblasts, that there were not microfractures, there was not bleeding. Today, we know that shock waves induce the cell differentiation, reproduction, and migration. And so, again, shock waves trigger a biological response. So again, there is a biological reaction, not a mechanical, just mechanical effect, and it is not produced by tissue injury or bleeding. We have many basic science papers, but one author that you will see very frequently is Professor Wang from Taiwan. Unfortunately, he's now retired, but he has given us a lot of information. And he performed studies in dogs and rabbits, and he demonstrated that there was in the tendon bone junction angiogenesis produced by the application of shock waves. This is a very nice study published by some researchers from Chile that are good friends of us. And this paper was published in the Journal of Shoulder, the British Journal of Shoulder. These authors have a great idea. They had a group of patients with a rupture of the rotator cuff that had an indication for repair of the rotator cuff. So they divided these patients in two groups. One group received shock waves 3 weeks before surgery, and the other group did not receive shock waves. And when they were performing the repair, they took biopsies and they compare the results, and they saw that was a very clear neovascularization and neolymphanciogenesis in those patients who had received shock waves. But there was a condition. This reaction appeared in those rotator cuffs in which the level of degeneration of the tissue was moderate or was not important, was a very high level of degeneration. But when the level of degeneration was high, there was no reaction. So we need the interaction of the stimulus and the tissue that is able to respond to it. This is another interesting paper. I was honored to be part of this paper. It was led by Dr. Cheng from Taiwan, who was Dr. Wan right hand, and this was published recently. And we have seen that shock waves can also enhance the quality of the cartilage of knee in rats. So this opens a very interesting field of research. So to give you a kind of update, still with this new information, we know that the angiogenesis is one of the key mechanisms by which mechanical stimulation acts, not mechanical activity alone. How a mechanical stimuli get a response from the cells? Well, this is through a mechanism that is defined as mechanotransduction. That is the ability of the cells, the capability of the cells to recognize a mechanical stimuli and react, as they can recognize the effect of drugs or hormones. Cells can also recognize the effect of pressure. And we all know that. We know that in some point of a tibial fracture, when we give some weight to the patient, we make the callus grow faster and bigger. And that is mechanotransduction. But even more, we are using mechanotransduction now because speaking, I am just producing a wave that is going to make your tympanos vibrate. So it is a very humble stimuli that will go to your brains and give you a reaction. It is in the ear cells that is a mechanotransduction, where the cilia of these cells are vibrating and creating a message going, a biological, a chemical message going to your brains. Imagine I tell you that you have won the lottery. If you trust me, you will have tachycardia, you will have mydriasis, you will have sweating, piloerection, many changes that are biological reactions to a very simple mechanical stimuli going to your ear. Well, the same we produce when we apply locally shock waves on a tissue. Just a basic example, but the cells can recognize that the mechanical stimuli is going to the nucleus of the cell, and there is a liberation of exosomes. And we all know how important are the exosomes. We are trying to treat patients today injecting exosomes. Well, shock waves release your natural exosomes and creates a response. And this has been proven in some researches related to heart, to the use of shock waves on heart pathology during heart surgery. And now we know that exosomes have a very important role in the mechanism of shock waves. Again, Dr. Wan showed us that after the application of shock waves, there are many changes, that vascular growth factors are released, that cell replication factors are released, that the concentrations of nitric oxide is improved, and that have as a conclusion the developing of new vessels. This is a paper that I was really honored to participate with Dr. Wang, in which Dr. Wang and Dr. Chen made a list of all the factors involved in the mechanism of shock waves. And as you can see, it's a very complex way of acting. But to make a resume of this, physical energy produces a biological response through the liberation of different factors that improve the blood supply and has as a conclusion, as a final consequence, tissue regeneration. But well, what about our practice? What about our daily practice? Well, in 2018, we were able to get accepted a paper in the Journal of Bone and Joint Surgery discussing the role of shock waves in musculoskeletal disorders. And we use the grades of recommendation proposed by the Journal of Bone. This grade of recommendation classifies the different techniques in A when there is a good evidence, and that means when they are A, that surgeons should change their practice according to this information. B, when there is a fair evidence with level 2 or 3 studies, and in this case, surgeons should probably change their practice. And we have two other different level of recommendations that are C, when there is conflicting of poor quality evidence, and I, when there is insufficient evidence. And we classify the use of focused shock waves and radial pressure waves in the most common indications in our practice according to this. Having this paper accepted by the Journal of Bone took 1 year, and we interacted with 3 reviewers. Was very hard, but we are very happy about the result. And as you can see here, we have a graphic, a table with the basic information. The use of focused shock waves in calcifications of the rotator cuff have a grade A of recommendation because there is a big amount of information. Here, just to show you a case, this is a calcification of the rotator cuff before and after 3 sessions of electrohydraulic shock waves. Another case in which we use a piezoelectric device. In this case, there is a calcification of the subscapularis, and this is the result, again, after 3 sessions that were performed with no anesthesia, ambulatory, and with no problem for the patient. We have several papers that we have published since 2003 related to our experience on this procedure, and I can send them to you, to those interested on them. These papers are very interesting. The one on the left is a comparison between the use of shock waves and open surgery for calcifications of the rotator cuff. The one in the center is one paper performed in Italy, comparing the effect of shock waves and the effect of arthroscopic surgery. And both papers, open and arthroscopic surgery papers, demonstrated that there were no big difference. There were not significant differences between the shock waves and the surgery. And the amount of complications was much less using shock waves. And on the right, you can see a paper that we presented in Korea in the International Congress of Shoulder and Elbow Surgery in 2016 with the team of Hospital Quirón from Barcelona, Spain, where we demonstrate that there was a big amount of savings using shock waves for calcifications of the rotator cuff comparing to arthroscopic surgery. What about the use of radial pressure waves? Well, at least when we published the paper, there was not enough evidence to support the massive use of radial pressure waves on calcifications of the rotator cuff. And unfortunately, in many cases, the information generated by focused shock waves is automatically extrapolated to radial pressure waves. But as I said, there are different techniques, different technologies, and for me, they are clear. I will show that to you later, different indications. Both focused and radial pressure waves cannot be advised in non-calcific tendinopathies because the quality of most of the papers, the ones who support that and the ones against that, are very poor quality. Especially if you see the information from the point of view of a shoulder surgeon. The inclusion criteria, the exclusion criteria is not good at all. We have a grade B recommendation for other pathologies like the lateral epicondylopathy of the elbow, the greater trochanter pain syndrome, patellar tendinopathy, and Achilles tendinopathy. So again, this is interesting. There is enough information to support the use when other methods, non-invasive methods, have failed. What about plantar fasciitis? Well, we have a grade of recommendation A, and the results are really close to 90% of good results, to the point that their consensus, the American College of Foot and Ankle Surgeons, include in their algorithm of treatment for heel pain the use of shockwaves. Finally, non-unions. Well, non-unions have a grade B recommendation. It is difficult to have papers level 1 including a big amount of similar non-unions, but the results are really interesting and are the good results when the indications are achieved, because we use shockwaves in non-unions when there is, and I am not speaking about delayed unions, I am speaking about non-unions when we have around 70% of good results. This is the case I got with higher, longer history of non-union. Was a patient that suffered a motorcycle accident and was suffering a non-union for 2 years. He got fractures of both hips and a fracture of the diaphysis of the femur, right femur. And he, at the beginning, was treated with an intramedullary nail. He got infected, the intramedullary nail was extracted, and he was treated with an external fixator, but with no response. And I just performed 3 sessions of electrohydraulic shockwaves, and you can see this patient was treated for me 10 years ago, that there is a progression, and in a couple, 3 months, we got a real difference, and we were able, not me, it was not my case, my surgical case, but the surgeon was able to release him from the external fixator. It would be interesting to have a webinar specifically in non-unions, but just today I want to give you an overview. So what about the indications? As I said, radial pressure waves are good, are effective, but for some specific indications especially. I can tell you that most of tendinopathies, perhaps the only exception is the insertional tendinopathy of the Achilles, in which I prefer focused shockwaves, but both technologies can be a good indication in most of the tendinopathies. The same for fasciopathies, the same for greater tuberosity pain syndrome. I prefer focused shockwaves, and it's not just my preference. There is a lot of evidence in the literature that high energy focused shockwaves are the best indication for rotator cuff calcific tendinopathy and non-unions. We can use both focus and radial pressure waves for trigger points, but I have put this indication closer to radial pressure waves because could be in some areas dangerous to use focus shock waves because of the chance of pneumothorax, and there is a very strong evidence for the use of radial pressure waves for spasticity, especially in children. What are the contraindications? Well, the presence of a malignant tumor or fetus in the area of treatment is a contraindication for radial pressure waves and for low energy focus technology. And for high energy focus technology, as I said, lung parenchyma, malignant tumor, open feces in the area of treatment, brain or spinal cord in the area of treatment. Anyways, we know that shockwaves are using, I could say, in experimental way so far for the treatment of Alzheimer, but not high energy, severe coagulopathy, and the presence of fetus in the treatment area. The level of risk of focus shockwaves is completely different to radial pressure waves. And that's why for instance, the European community, they are classified as different devices. And that's why the Federation of shockwave treatment and many other institutions related to shockwaves recommend that the use of focused shockwaves is a medical procedure because of the level of risk and because of the type of indications with whom we live. Because to treat a non-union, it is not just putting a shockwave device on the area. You need to be trained to make a good interpretation of the X-rays, know when to give weight to that non-union, the type of immobilization, and when it is necessary to move on to surgery. We have frequently not important complications like erythema. This is, for instance, when treated in the myofascial pain trigger points with radial pressure waves, but there are reported injuries with focus shock waves. This is a patient I treated with focus shock waves. He had a calcification of the rotator cuff, and after the first session, he developed an edema of his arm. I stopped, I controlled him, and finally this disappeared, and I applied 2 more sessions, and the calcification disappeared. I have seen, like this case that was treated by a physiotherapist, hematomas. He was trying to get rid of this calcification with radial pressure waves. Well, the calcification did not disappear, and the patient suffered a hematoma. What we did was wait, and once the hematoma was resolved, we apply shock waves, focus shock waves to the calcification. And we need to know that the use of focus shock waves in areas close to big vessels and big nerves can produce complications. There are several papers published related to ulnar neuropathy and some other complications that are not common, like osteonecrosis of the humeral hair. But this, there is someone speaking. This was a complication. Dr. Singh, please. This was a complication that we can argue because the patient was receiving corticosteroids before receiving the shock wave. Sometimes complications are considered related to shock waves, and it's not that way. This is an interesting case, a patient treated with plantar fasciitis, and the patient developed a pathologic fracture after the application of focused shock waves. There are some burns that have been reported, and even with the use of radial pressure waves, There are some studies that have seen harm in developing chicken embryos. So this is an alert to the use of any kind of waves in the area in women that can be pregnant in the abdominal area. But for sure, the most important and most frequent reason for having a poor result with the using of shockwaves is a misdiagnosis. And we need to know what are we treating. We need not to treat symptoms, but to treat diagnosis. Because in many cases, when the use of radial pressure waves and focused shock waves is not done by orthopedic surgeons, the quality of the diagnosis drops because we are trained to diagnose musculoskeletal pathology. Another point is not, as we say in Spanish, not to put the cart in front of the horse. Sometimes people developing a therapeutic procedure or who have just bought their first shockwaves device are so interested in the use of the therapeutic method that they don't care about the diagnosis. Again, we need to know that the basis of treatment is to have an accurate diagnosis. We, the Federation of International Federation of Shockwave Treatment, are open to collaborate. We have several countries around the world who have joined us. The biggest shockwave societies, the Chinese society, the Brazilian society, European societies as the French one, and hopefully we will have an Indian society soon. This is the web page. We have a publication. These are some volumes, one dedicated to China, the other to Brazil. Hopefully we will have the Indian volume in the future. And we have an online fellowship for those who want to get deeper in this procedure. You can, again, get in touch with me if you need any information about that.
Thank you, Dr. Daniel. So it was indeed very informative, in detailed talk, and the best part of the talk is you have covered the complications also, which at times as a surgeon we try to avoid it because information and knowledge should be in detailed. So it was a very excellent talk. So over to our moderators of the session, Dr. Jujhar Singh and Dr. Bishnu Patra. So please hand over to you.
Thank you, Dr. Daniel.
So hello everyone.
Hi,
Yeah.
Dr. Jujhar. Yeah, please go ahead. Please go ahead.
Hello sir. Hello sir. Sir, please, sir, please. Then I think we'll be inviting the next talk of the webinar. So I think before that, if you want to comment upon something or if there are any few questions which I think we can discuss, I think that we can come to if we have time.
Yeah, just few questions, couple of questions like to Dr. Daniel. Dr. Daniel, what are the obstacles why this procedure still not popularized world over?
Well, it is difficult to know that. This has been used in Europe for more than 30 years with very good results. And in Latin America, it came from Europe and also is well developed. But for instance, in the US, is growing in the last years. So it is difficult to know if this is related to commercial reasons or the way. In fact, I get to know the shock waves because of a coincidence, just going to a shoulder meeting. So I think there is not a big planification about what happened with the shock waves.
Okay, one more question. In which conditions your shock wave therapy is the first line of therapy? Because, for example, in non-union, we have so many procedures. In which condition you feel that shock wave therapy will the first line compared to any other existing methods?
Okay, it's a very good question. I could say almost never, because a patient with a tendinopathy, I always begin with rehab and with other measures just to change the reason that I think is having a big influence on that tendinopathy, the way they practice sports or the way they work. So shock waves mostly are indications for chronic tendinopathies. And
Okay.
I am very happy when I received a patient that has been treated with no result for 1 year, have done many sessions of physiotherapy, try different things. That is the typical patient I treat with shockwaves. Because one point that we must consider is that we are modifying the quality of the tissues, we are triggering a biological reaction, and that doesn't happen from one day to the next one. It takes 3 to 4 months to get the best result of shockwaves.
Okay.
So
Okay.
if a patient began yesterday with a Achilles pain, and I tell him, okay, you will need to wait for 4 months, he will not be happy. We
Okay.
know that there is a percentage of patients that have very good results with physiotherapy, and generally we say for a tendinopathy, 80% of the patients will respond with rehab. We have 20% that will not respond. Of that 20%, around 80% will respond with shockwaves.
Thank you. Thank you for nice
So what I
explanation.
understood by Dr. Moya, that as a surgeon, we should always have plan A, plan B, and plan C.
Yeah.
So it is not a plan A, but as a surgeon, we should always have a plan B, because we cannot give 100% results with plan A. So we should have everything in our kitty. So Dr. Jujhar, you were trying to say something?
Yeah, I was actually wanting to ask Dr. Daniel. First of all, it's a wonderful, innovative talk, and it's quite an
Okay.
unexplored territory that we are venturing into, being an orthopedic surgeons. My apprehension regarding that talk is that the how do we practically take it into the ground? Because again, when we practically talk about giving that therapy to the patients and customizing it for various tendinopathies or chronic non-unions or various types of pathologies, so is there any protocol? Because I don't know, because this is obviously this time is very less to discuss all the horizons of this. That is why I think we have just got the brief overview. But I think for different types of pathologies, there has to be different regimens and there have to be different type of treatment durations so that the application cannot be same for everything. And we need to have a cutoff limit. We need to have a starting limit. We need to tone it down or increase it. So I think I should have just a brief comment from you, Dr. Daniel. So what are your comments about these? How is the technically it is challenging to bring that thing into the practical ground?
Good. Thank you. Thank you for your nice question. Yes, of course, absolutely. There are different protocols, and protocols in which we not only consider the level of energy, the number of pulses, the frequency, but also how we give the patient a protocol to go back to sports, the exercises we include. So I always say I can put my grandmother to apply shockwaves because it is just putting something, a device or a applicator on the skins, putting some gel, but the art of using it is the art that we orthopedic surgeons have, knowing the chronology of the pathology. So when we discuss with other specialists, specialties, we realize how far are them from the topic, because we have, at least in Latin America, anesthesiologists that work on pain and uh, begin to apply shockwaves. Apply shockwaves is easy. The point, and we orthopedic surgeons, and I will give you rid of your concerns. You as an orthopedic surgeons, you know the most important topics and the most important information about how to deal with this type of pathologies. But of course, your question is very good. We have protocols, and there is one point I must confess is the problem of the shockwaves. And the problem is that we have several devices, different models, different trademarks, and every device has its own performance. And you, as the one providing the treatment, you need to get to know the performance of your device. And besides having protocols, you will make the fine tuning of how to treat your patients. But yes, there is a lot we could discuss about that.
Yeah, so
Thank you.
interesting. So, Dr. Daniel, what I understood that it is not only protocol driven, it is instrument driven also. And
Yes.
Dr. Jujhar, I'm very sure that in a coming time, Dr. Daniel will release the protocols on various platform. I will work with him.
Yes.
So, because we are running short of time, I want to take this opportunity, Dr. Daniel, if you allow, to invite Dr. Ram to
Of course.
give our second talk of the evening. So, Dr. Jujhar and Dr. Bishnu, please, over to you.
Yeah, thank you. First of all, I'd like to invite Dr. Ram and congratulate him for a well-deserved victory. I think we can
Yeah,
talk later.
today he won
So,
the election also.
yeah,
Yes,
so
yes, yes.
again, so it has to
Thank
be
you.
a good day for all of us. So I'd like to invite you, sir, for your talk on the further clinical applications, scientific evidences regarding the shockwave and your views regarding the same. Most welcome, sir. Please
you.
share your thoughts and share your screen.
Thank you, Jujhar. Thank you, Karun. Thank you, Bishnu, for the wishes. So I will just share my screen. Sorry, that's not the one. Say wait a second. Can you see it?
Yes, yes.
First of all, thank you. Thank you for the opportunity. I think Professor Dr. Daniel Moya, my good friend, has talked in detail about what is shockwave, the types of shockwave, focused and radial, what is the indication generally, and also specifically about the mechanism of action. My experience of using focused shockwave is because I was in England for 12 years. And then in that period, we always stick to nice approved guidelines. So following that, I started to use the focused shockwave for some conditions of the shoulder. So that's my experience. In fact, generally, as Jujhar said, in India, shockwave therapy is not very well known. And second is people often think shockwave means, is it shark to wave? It is not shark to wave, it's gone. It is shockwave. And then people will also think, patients will also think that shockwave means giving some shock. It is not actually shock, it is a mechanical pressure wave. So there are a lot of terminology changes which Daniel is working through, and also different protocols. Because if you see the published studies, there are so much confusion about the protocols and the terminology. With that background, I'll just go straight to the case because it's a practical application talk. 57-year-old lady, which you will see in your practice, right-handed school teacher, nil medical problems, complaints of pain in the left shoulder for 2 months, got worse for the last few weeks. There was no history of trauma. She cannot move her left shoulder sideways, or rotation is difficult. Activities of daily living disturbed, no sleep. She cannot lie on the left shoulder. This is the clinical picture, and that's the range of movement of the left shoulder, hardly around 60, 70 degrees of forward flexion, abduction. And if you look at the rotations, there's a right side, left side rotation is restricted to sacroiliac joint, and external rotation is around 20 degrees. So with that, we did an X-ray of the shoulder. AP view looks okay. Lateral view, for somebody who is not seeing much of the shoulders, it looks okay, but you could see a faint calcific deposit on the back of the shoulder. So we got an MRI. This is the MRI scan showing posterior calcific deposit. Normally you see on the top of the supraspinatus, but here Sometimes you see on the subscap, sometimes you see on the back of the cuff. So this is on the infraspinatus and teres minor adjacent. That's a big, large calcific deposit. So we have a 57-year-old lady. That's a calcific deposit. I just put an arrow mark there for you to see. So 57-year-old lady with the calcific rotator cuff sorry, let me just minimize this thing. With the calcific rotator cuff tendinosis, with the painful stiff shoulder, how to go about? What would be your protocol to begin with? Jujhar, what do you think? Briefly, then I will move on to my talk. NSAID, steroid, physio, ESWT, US guided needling or buffetage, arthroscopy. Washer, debride. Jujhar, can you talk? Just a couple of words and then I will move on.
So I think you are able to hear me?
Yes, please.
Yeah. Yeah, so I think all of the options which you have listed, I think the NSAID, steroid injections, physiotherapy, all these can be one of the starting points by many of the clinicians. But yes, initially we start with the physical therapy along with basic anti-inflammatories, and then we can move ahead, see the picture of the patient. We can even go ahead with the steroid injections as well and use a hypervolume saline as well to open up the shoulder. Now that we have various minimally ultrasound guided imaging as well protocols. So I think all these things can be helpful. But then again, yeah.
Bishnu?
So, yeah, but then again, I think we need more picture and we need to see how the patient responds to all of them, because none of them has been shown to be completely resolving these types of pathologies. But yes, I think steroid injections, especially the high volume injections and NSAIDs along with physiotherapy will be my first line.
Okay, Bishnu?
I know that any such patient will be starting with NSAIDs, but steroid injection I don't prefer, and the ultrasound guided needling I do. So NSAID and physiotherapy, it doesn't work. I straightway go for arthroscopic excision.
Yeah, US guided needling. Yeah, okay. Thank you. So let's see the common condition. We'll talk about the calcific tendinitis mostly occur in women, age between 40 to 50. Idiopathic reason, we cannot relate with any particular traumatic condition, but it is a very painful condition, often acute or subacute presentation, and the patient presents with typically intermittent attacks afterwards. Probably when the calcium is like a toothpaste-like material, it causes inflammation, cause severe pain. When it solidifies or settles down, the symptoms do settle down. So that's a clinical examination. You see painful, stiff shoulder, muscle testing would be difficult. That is X-rays. As you see here, you could see the calcific deposit, most commonly supraspinatus. Sometimes you see subscap or in the posterior cuff as well. And MRI scan can pick out large deposits, but if it is a tiny deposit, sometimes is not picked up by MRI, and the X-ray is often very sensitive. So do not miss to have an X-ray if you have a patient with a painful shoulder. So the stages, this is definition by Uthoff: pre-calcific stage, metaplasia into fibrocartilage, then calcific stage, formation and resorption, and the post-calcific tendon reconstitution. So this is how the formation to resorption, latest theories put up by this paper in 2018. So the cells were found to be mostly chondrocyte-looking cells, probably from tenocyte, or could be tendon stem cells that are able to differentiate into chondrocyte. And the deposit contained a poorly crystalline carbonated apatite crystals. And these crystals might have a protein called osteopontin that is only identified regulating factor. These apatite crystals induce the influx of leukocyte inflammatory reaction and release of a lot of these interleukins and inflammatory mediators. Sometimes spontaneous resorption can occur when these crystals migrate into the subacromial bursa. They can cause some pain or stiffness, but then it resolves. And the mechanisms of spontaneous resolution and why it disappears still need to be elucidated. We don't know exactly why some disappear, why some stay. These are all the classification. Very interesting to note. There are a lot of classification for classification for these calcifications. So this is the radiological classification: sharp, dense, blunt, dense, sharp, translucent, blunt, translucent, but that is descriptive. And this is the French Arthroscopy Society classification that sort of describe the stages in process. The first, type A, first picture is a homogeneous calcification with well-defined limit. Type B is a heterogeneous fragmented calcification with well-defined limit. Type C is a heterogeneous with poorly defined with punctate appearance. And type D is the dystrophic calcification of the tendon insertion, sometimes what you see in tendo Achilles, etc. Bosworth classification described that in terms of size. Because if you see a large deposit, the deposits are not lying outside the cuff, it may be part of the cuff. So when you have a large deposit, we have to think in terms of doing something to the cuff. The cuff has to reconstitute or we have to repair it. So the sizing does matter. The conservative treatment is a 90% NSAID, steroid, physio, ESWT, and needle aspiration. These are all the factors that can cure 90% of calcific tendinitis. Let's talk about each. Physiotherapy, steroid injection, ultrasound, and pulse electric therapy showed improvement in pain by coherent review. Steroid is commonly used to give symptomatic pain relief, but there is no conclusive evidence that it resorbs the calcium. It reduces the pain and controls. Sometimes may hinder the cell-mediated response according to Toff. Needle aspiration babatage is widely practiced. This is done under local anesthesia, ultrasound guided. The aim is to break the crystals, open up the channel so that the cell-mediated progressive resorption will happen. It may be painful for a few days, but then it sets in. And the best result will be seen in acute painful condition or in a resorptive stage. So this is the evidence of the paper, systematic review, showing 908 patients, safe technique, high success rate, low complication rate. ESWT, I started to use because I was in England and it was approved by NICE guidelines to use shockwave therapy. Focus shockwave therapy is preferable for calcific tendinitis of the shoulder. In India, I started using the urologist application of, this is the urologist using machine with the Shyam and the ultrasound control. This is the one I started to use for calcific tendinitis. How does it work? I think Daniel Moya had given the very illustrative talk. Remember, number one is a mechanical effect, increase the pressure through the deposit fragmentation, resorption. Number two is a molecular effect, inflammatory response, neovascularization, and last is the analgesic effect by these denervation of pain receptors and other mechanisms. So we have a combination of three effects, and the use of high energy is preferred in calcific tendinitis. How do I treat? Use the focus ESWT for this particular indication, 3 settings, ultrasound guided marking of the spot, simple analgesic cover, mobilize as comfort allows, and muscle strengthening starting from 6 weeks. So let's see the cases. This is a 57-year-old lady, painful left shoulder for 3 months, restricted range of movement, unable to do ADL. And this is her after 3 months of ESWT. The calcium totally disappeared, and you could see the range of external rotation that's full. And you could see the forward elevation and abduction, which is recovered full range of movement after therapy. Now come back. This is the resolution after ESWT because it disappears the calcium also. That means the tendon is also reconstituted. This is the case example I started off showing 57-year-old right-handed school teacher with a painful stiff shoulder for 2 months. It got worse for the, sorry, it's not advancing. Sorry, guys, just my PowerPoint stopped responding.
No problem, Dr. Ram. You can go extempore also.
Yeah,
I know your caliber.
let me, okay, let me just go back and restart it.
Sure, please go ahead. I think by the time Dr. Ram sorted out, we can take few questions. Dr.
Yes,
Jujhar,
yes,
please,
yes,
please,
yes, yes.
please
I
start
think,
a question and session with Dr. Daniel. Meanwhile, Dr. Ram sort out that issue.
yeah, definitely. So I think one of the results which Dr. Ram has shown, the calcific tendinitis part, and they are actually very encouraging and looks quite promising. Any clinical examples or any of your experiences regarding these types of cases, Dr. Daniel? Can you brief upon this aspect?
Yes. Well, I have used shockwaves for 24 years on calcifications of the rotator cuff. My first patient was a calcification of the rotator cuff, and uh, for me is if we do not have good result with physiotherapy, my first indication are shockwaves. Focus shockwaves, high level of energy, and they are just 3 sessions. And as Ram showed, including rehab, strengthening the muscles, because I always say that shockwaves will not recover the strength of the muscle, the range of motion, and the scapular dyskinesia. We need to include a rehab program, but the results are really very good. We have published several series on that, and if I get the worst that could happen is that nothing happens, and you need to move on to whatever you want, barbotage or with ultrasound guided needling or surgery. It's up to the surgeon.
If we are just talking about calcification, I think this shows very good results. But if we are talking about, again, the rotator cuff pathology, if that is associated with all these things, talking about some amount of tendinosis or partial cuff tears and all those things, so will you be still preferring the shockwave therapy as the first line, or will your management differ in that?
No, I was very lucky that I trained with Dr. Rockwood several years ago, and I can tell you that one of the most important things I learned with Dr. Rockwood is rehab. In fact, being him a surgeon for almost 25 years, the protocol that was used, the organized protocol to rehab patients, was designed by him. So I think that the rehabilitation of the shoulder is an art, is a
Yes.
craft. You need to adapt to the patient. There are not formulas that you can use in all patients, but my results with non-calcific tendinopathies, including tendinosis and partial tears that do not have indication for surgery, is very, very good with rehab. We use a home-based program that is supervised, and I seldom use shock waves or radial pressure waves in patients with tendinopathies of the shoulder with no calcification.
Okay, thank you.
Yeah, Dr. Daniel, I have one more question. What is your experience of SOCF in carpal tunnel syndrome? Any experience?
No, I don't have a personal experience. I know that there are some papers dealing with that, but I am a little bit orthodox for the indications of shockwaves. In fact, I have a couple of patients talking about hand that I know that there is evidence, but I was a little bit reluctant to use shockwaves. And some colleagues sent me the patients because they saw good results with other pathologies. And I have treated trigger points, trigger fingers on hand and a decurvent tenosynovitis, and I was surprised by the results. So I think that, but with carpal tunnel, I don't have personal experience yet.
Okay. Dr. Ram is ready, I think.
Oh, sorry for that. Just shut down automatically. So I had to restart my laptop. So come back to this 57-year-old lady with a calcific rotator cuff tendinosis with a painful stiff shoulder. We talked about the options. So that is her after focused ESWT 1 month later, showing the range of flexion abduction. And the range of internal, external rotations. So that's the result for her. But not all patients have disappearance of calcium. This 66-year-old gentleman with severe pain, right shoulder, cannot move. And this is outcome after ESWT. Pretty good results, is much better. But I took the X-ray, but the calcific deposit is still remaining same size. So it has been shown as well. A proportion of them can still save, but the patient's functional recovery is there. So this is what Dr. Daniel Moya was talking about, the other effect of mechanical pressure wave than mechanical. So ESWT randomized controlled trial shows 86% disappearance of calcium, 14% reduction in the size of calcium. In control group compared, there is no disappearance and only 8% reduction in size. So long-term results, this is a prospective study of 31 shoulders over 2 to 3 year follow-up. You see complete resorption 57, partial 15, unchanged 27, but there is 90% good to excellent results with the symptoms recurred only in 7%. Side effects very minimal, mild pain, redness of skin, ecchymosis. You had to check if the patient is on blood thinners, otherwise you could give safely. It's a very safe application. How does it compare with arthroscopy, retrospective comparison study? Radiologically, no calcific deposit, 86% in scopic group compared to 58%, but functionally, there is no difference. And this is the latest review, systematic review and meta-analysis of randomized controlled trial of all RCTs comparing conservative versus operative treatment for calcific tendinosis. 27 studies, 2,212 non-operative, 140 operative. Visual analog scale and constant Morley score were checked. Resolution of calcium deposit was also checked. The results show both modalities, both conservative means here ESWT or ultrasound guided injection, needling, compared to surgery, all modalities had significant improvement in function and pain. That is statistically significant improvement. Reasonable, hence, therefore, it's reasonable to try ESWT or ultrasound guided needling as the first line of treatment as per your choice. Surgery, of course, showed a larger improvement in functional outcome, scored but comparable pain reduction to the non-operative intervention. So when do you consider operative treatment? Indication in my practice, symptoms lasting for more than 6 months or recurrent symptoms. You tried ESWT, you tried injection or ultrasound guided needling, but still persisting recurrence, I consider. And if there is a large deposit, sometime I consider, but off late I'm considering more for shockwave therapy. What we do surgery, arthroscopic excision of calcium deposit, plus subacromial decompression usually performed, rotator cuff repair if the deposit is large or if there is a defect. Subacromial decompression is not routinely necessary, but if there is inflammation of the significant bursitis or secondary impingement due to tender thickening or diffusely spread small calcific deposit, they may benefit from SAD. And these are the indication for acromioplasty. And this is our experience, published from UK, because we've done quite a good series of calcific tendinosis operatively as well in the UK. This work was presented in the British Elbow Shoulder Society, and we took 60 patients of arthroscopic excision of calcium. It's a huge number who had subacromial decompression, no formal cuff repair. The mean age was 51 years. The functional outcome, X-ray and ultrasound were checked up, and the mean constant score was 82, 90% excellent, good results, 10% fair. There is no poor results at all. And 43 patients had intact rotator cuff with no defect. 12% had partial bursal defect. 3 patients had full thickness tear. 4 out of 15 were only symptomatic. 2 patients had recurrence of calcium. So 75% cuff healed, 25% had defect, 6% remained symptomatic. This was only calcific excision. There was no attempt at repairing the rotator cuff. So thereafter, what is in my practice I do is based on this. You need to know about the anatomy of the rotator cuff. You have a bursal side and you have articular side. The bursal side is a thick collagen, parallel orientation, greater tensile strength. So often the calcium is deposited on the bursal side. So a removal of large deposits of calcium can result in some weakening or a tear or a defect. If significant, then it needs repair. So this is what we do when we do arthroscopically. This is after decompression. As you could see, the calcific deposit is marked by this marked intense inflammation on the cuff. You can put a needle and locate the calcium, double confirm it. Sometimes if you need to do an X-ray to check it. And this is the calcium expression. Make a small nick or a stab incision and use the shaver. As the calcium comes like a toothpaste, you keep the shaver close to the incised area and remove everything. Every calcium you remove instantly. Otherwise, this can cause some inflammation and pain post-operative. So if you once you do that, you debride that area and see the defect. So you can squeeze it out. Then you can open out that area and debride the chalky deposit as well. So that resulted in a partial defect of the cuff. So I just put a side-to-side suture with absorbable and non-absorbable combination to make it better. And this is her at 1 week post-operative. Absolutely, there's no evidence of calcium deposit on the X-ray. Happy patient. And recently we had one patient with extensive deposit. As you see here, this is the rotator cuff insertion. The calcium deposit is way deeper in the muscular plane, and that is quite extensive, like 3 by 2 centimeter calcium deposit. So this is me after removing. As you could see that there is quite a lot of deposit. You could see the muscle belly on either side. So you could try ESWT, but I thought it is too big and too deeper to try that. So here I put an anchor and use the suture to repair it. So if there is a large calcific deposit, we tend to go for repair. Otherwise, simple removal is enough. So conclusion, calcific tendinitis, first line, NSAID, rest, steroid, physio. Consider focused ESWT shock wave as one of the good choice, as well as equally on the literature published, there is ultrasound guided needling of Babatage, if some surgeon's choice. And if symptoms are more than persisting or it is a recurrent calcific tendinosis, consider surgery. Arthroscopic excision of calcium with subacromial decompression if required, and repair of the rotator cuff if significant defect, like more than 25% of the thickness on the bursal side or more than 1 centimeter width, it needs repair. This is my summary about calcific tendinosis. And Daniel was talking about forming the society. In fact, when he visited us in Chennai in September, we created this Indian Shockwave Association, registered as a society. Anybody who is interested in learning or progressing with the knowledge and technique and application of shockwave, we can learn and grow together. You can directly contact me personally or by email. Thank you very much.
Great, excellent talk. So, Dr. Ram, I think life is not about starting. Life is all about restarting.
Yes.
So success
Correct
comes
for my laptop
restart.
today.
Success always come with a restart, because at times we start well, but we leave in between. Dr. Bishnu, just to add a point, Dr. Bishnu is our professor and head of the department at AIIMS Bhubaneswar, and credit to him, he has almost 17 theses going on under his leadership at AIIMS Bhubaneswar on the topic of orthobiologics.
Yes, yes.
So I think, Dr. Bishnu, this is a new dimension to you to start a thesis, shockwave therapy. Is it not, Dr.
Yes,
Bishnu?
yeah. Actually, I like to say that. Thank Dr. Ram is very nice presentation about, and I could see the nice videos of arthroscope videos. The calcium coming out looks very pretty good. And
That's
one
the
thing,
most rewarding. That's the most rewarding surgery in the shoulder, by the way.
that appearance is very very rewarding, and you feel good. Something like, yeah, I'm doing my job. And one thing I like to say that once in a conference I got to saw these instruments. These are quite huge instruments, that extracorporeal shock therapy. And just wanted to know, because at present I don't have that instrument in my place, though the urologist guys have. I don't have access to that, because maybe it's a bit too complicated to have two departments and shifting all this stuff. Just like to know where to get the right instrument for a beginner, because many of the viewers who are here, they like to start with the minimum procedure. So you cannot straightforward go for a multi-crore or multi-lakh instrument, so that you never know how it works actually. So anybody of you, the panelist, can let us know what is the first instrument or first equipment you can really go for this.
Yeah, I think to say we had a full-fledged urology using equipment, and it is easier for us to use it, but it is not always the case. And nowadays, I think recently we have we have a couple of companies, they are coming in with the focused wave, with the with the radial pressure shock wave. There are a lot of companies, they are selling it, even Indian companies. But the focused shock wave, few companies are coming in, trying to establish, and with they are coming up with the options of smaller size. The big size actually is not necessary. If you add the ultrasound guidance, CM guidance, the urologists use CM guidance, so it is big. And majority of European surgeons also use ultrasound guided, but ultrasound guided with the thing, it's quite very expensive. So I think we have to look at the future. The more models, more companies will be upcoming to India. At the moment, the market is very small for them.
Actually, I am soon starting a biologic clinic with all the armamentarium, but this armamentarium lacking. So, I'm going to make one of the good center for orthobiologics in AIIMS Bhubaneswar, because this is very much important for me to keep it as armamentarium, because with this I will have complete resources for orthobiologics. That is why I wanted to know, because wherever I've gone, they've shown us very huge equipments, and those huge equipments are really doesn't fit to your very clumsy OPDs, and where you have very high volume OPD, almost 500, 600 patients coming to OPD, and it's become very tough for us. So I just looking for a very catchy and cute instrument where I can put anywhere I want.
Just one thing for Dr. Bishnu, I think that when buying a device, you should consider that has all the approval from the regulation agencies, that you can see that there are some publications on the literature about that device, but every time I have bought a device, I have asked people I trust, doctors I trust, what do they think about the device, what was their personal experience. And another point that you must make sure is that you will have a good service after buying the device. Because if
That is
the
very important.
company, if the company disappears after you buy the best device of the world, it's not a good deal for you.
Very right.
Has happened. At least in Latin
Warranty
America,
guarantee should be there for 5 years.
Yeah. I just want to tell you that we have a WhatsApp chat for people interested on shockwaves where we discuss cases. So everyone is welcome. We are organizing an international meeting in Rome next year for May. We will decide the date, but we will get together from all over the world to share information and things like that. And to Dr. Singh, I want to tell you that we have a tradition in Shockwaves that to share the secret protocols, we always do it sharing chicken tikka masala. That's the way.
Okay.
Thank you.
Very nice.
I think we have already covered many things, and also went through 1 hour and 23 minutes. It's a nice
Good.
And now I'd like to hand over to the chairman of this webinar, where he can give the concluding remarks, and we can wind up. Dr. Karun.
I think Dr. Karun sir is offline as of now.
Okay. So
he's
Dr. Dharshan,
he's gotten disconnected.
Dr. Dharshan can do the needful.
No, sir. So I think you can do the honors. But I mean, it's been a great webinar. It's quite eye-opening. I'm sure for most of the individuals, especially budding orthopedic surgeons, this is a completely new aspect or dimension in orthopedics. None of the curriculums, in most of the institutes anywhere, will actually go and teach you anything about extracorporeal shockwave therapy or ultrasonic therapy or any of this. And I'm sure none of this is ever asked in any of the exams that any of the postgraduate students also undergo nowadays. So this is a big new horizons, if you want to call it.
Now that, but I have just a small comment actually.
Yes, sir.
Now that this extracorporeal shockwave therapy has been going into a bit of a disregard among the urologists actually. So they have been moving towards the focused therapies as well. Now they're coming towards the very small lithotripters, which are actually quite handy and they're quite small as well. So they were actually the first ones to get hands to the robotics as well. We are the late enters. So orthopedicians are always lagging behind, I think, the urology people. So I think now that they are going out of this thing and they are coming to the portable thing, I think we should march ahead of them and devise something, as Dr. Bishnu very rightly said, that we need some portable devices. We need some things which we have readily available in our OPD so that we can at least first get a hands-on, train people, get trained ourselves, and then apply on the patients with full trust as well as with full enthusiasm and belief. If we are not ready with all these things in our repertoire, then obviously we will not be sure about giving these therapies to all our patients. So I think machine equipment, learning about it and keeping it very handy and portable one is very important.
Yes, yes, I agree
Very
with you
rightly said,
completely,
Dr. Jujhar. But I think today's talk is about a very new entry to our orthopedic world, especially in India. So I think with the given insight by Dr. Ram and Dr. Daniel, I'm very sure that new instrument, handy instrument, will always, chances that we will have, and we will have upcoming new entries to this world.
Yes.
Because many orthopedic surgeons will get inspired with this talk, I'm very sure. So, Dr. Any questions further? Dr. Jujhar, Dr. Bishnu?
Yeah, no, yeah, all over. We like to now we'll wind up with your closing remarks.
Yeah.
So, any remark by Dr. Jujhar? Dr.
Yeah, so I think we had a healthy discussion while I think while most of the talks were going on, and I think we can take this further by protocol-based learning and our individual levels, as well as we can devise some protocols ourselves and get together and patch up again so that we can brainstorm towards these therapies. Yeah.
Okay.
Dr. Dharshan?
Yes, sir, I agree. I mean, this is something new, and we need to explore more regarding its efficacy, if you want to call it. And unless and until more and more people get used to doing it and practicing it, actual results, especially for a large series, is difficult to achieve, as indications are maybe slightly limited, and it's not the first line of therapy, as even recommended by Dr. Daniel Moya, sir. So, if at all we can come up with a sort of a multi-centric trial or something of that sort, or a study, and I think that would definitely help everyone.
Yeah, excellent. So, with this note of learning from last 1.5 hours about shockwave therapies, about the insight given by Dr. Daniel Moya and Dr. Ram, I would like to thank both of our speakers for giving us opportunity to learn about this new science of orthopedics. And I'm very sure ourselves being moderators and the event organizers and the audience would have learned a lot. And I'm very sure whatever new questions will come, Dr. Daniel and Dr. Ram will answer this question, offline also. So with this note, I thank Dr. Ram and Dr. Daniel, our moderator, Dr. Jujhar and Dr. Bishnu. Dr. Darshan is there. So with this note, I would like to conclude this session with a hope that next session even would be more interesting. So next session will be in the month of April. Dates will be announced soon. So meanwhile, thank you very much and do take care of yourself and your health. Thank you.
Thank you.
Thank
We'll
you so much,
conclude
sir.
this
Thank
session.
Thank
Okay.
you.
Okay. Thank you.
Thank you.
Okay.
Good night, everyone.
Thank
Bye-bye.
you, everyone.
Good night.
Thank you,
Good night.
everyone.